Hello, everyone. Welcome to today's webinar, Braiding Funding Streams to Provide More Person-Centered Care for People with Complex Health and Social Needs. This webinar is hosted by the Center for Healthcare Strategies and is made possible through the support of the California Healthcare Foundation. Next slide. Before we get started, I'll just go over a few quick logistics. There will be a moderated question and answer session following the presentations today. So you can submit a question online at any time just by clicking on the Q&A icon that's at the bottom of your screen. There will be a recording of today's webinar posted online at chcs.org. And as participants, everyone will receive an email when that recording is available, along with the slides. And we'll also share the slides in the chat for download. Next slide. So for the agenda today, we'll briefly share some introductory and background remarks, and then we'll hear from 3 California organizations that are using braided funding strategies. And these include organizations that provide aging and disability services, housing services, and specialty behavioral health services. We'll then have ample time for Q&A. And I'll just note that this webinar builds off an issue brief that was just released earlier this week. And I'll share a link in the chat to that now. And that paper is featured later in the slide deck as well. Next slide. The Center for Healthcare Strategies is a national organization working to improve care for people served by Medicaid. This slide has some more detail about who we are and the work that we do. And you can learn more about us at our website, which is chcs.org. Next slide. So we are lucky to have a really wonderful group of presenters today who will share their experiences and insights with us. Our 3 presenters are Debbie Toth of Choice in Aging, Katie Wilbur of RH Community Builders, and Jean Straub of Children's Institute. My CHCS colleague and co-author of the brief, Sarah Triano, will be moderating the Q&A. And then we're joined today by Melora Simon, Associate Director for People-Centered Care at the California Healthcare Foundation, who will share some opening remarks. Welcome, Melora, and we can go to the next slide.
Thanks so much, Logan. It's great to be here with so many of you. Just wanted to say a little bit about why we're here. We know that braiding is really important for delivering person-centered care, which, as we've kind of heard from people with complex needs themselves, is low barrier and comprehensive and integrated. We also know that braiding is really important in the context of CalAIM. So we've set up a resource center, and today's webinar and the issue brief are part of the many resources that are listed there. I did want to highlight one that we're particularly excited about. It's a project where we talk directly to people with complex needs and their caregivers about what their needs and experiences are. And so you'll see the link to both the resource center and that report. Thanks for being here.
Thanks so much, Melora. We can go to the next slide. And we have a large audience today from across the country. Our presenters are all based in California and will be speaking to their work in California, though we know that braiding Medicaid funding is top of mind for providers and other stakeholders across the country. So I'll just briefly share some background and recent updates to provide a little bit of context for the presentations today. First, we'll hear about 2 components of the CalAIM initiative, which is a multi-year care delivery and payment reform initiative. And those 2 are ECM, or Enhanced Care Management, and community supports. Notably, these benefits have really expanded both the types of services and the types of organizations that are eligible for reimbursement in Medi-Cal, which is California's Medicaid program. The CalAIM is currently authorized by both 1115 and 1915B waivers through 2026. It's important to note that there are many states that are covering similar services to these through a wide range of different mechanisms. And then I'll just highlight that the California Department of Healthcare Services just recently released a concept memo really stating the intention to continue and strengthen initiatives that include ECM and community supports in upcoming waiver renewals. There's a lot more information in the sources of this slide if you're interested in digging in, but we wanted to provide that background with the understanding that how these services can be sustained is very important for organizations that are thinking about their planning to support their financial sustainability. So we can go to the next slide and just quickly define some of the key terms that you'll hear on the webinar today. First, braiding. Braiding can be defined as a strategy that combines funds that originate from multiple sources, but are all designed to support a common goal. And it's critical that with this strategy to carefully track each funding source and meet all of their kind of source-specific requirements. Then sequencing is a strategy of applying multiple funding sources in a specific sequential order. Stacking, also known as layering, is a strategy to combine multiple funding streams by using layers of funds that supplement a core funding source. So I'll go through these quickly, but I think our presenters will bring these terms and what they mean to life when they speak shortly. And on the next slide, I'll just note that one of the things that matters most about braiding is first the why, which is on this slide, and then we'll get to the how. At a high level, organizations pursue braided funding strategies to serve anyone who walks in the door, to provide more comprehensive services that are really designed to advance more integrated care, extend the services that can be provided, that including coordination of transitions, and address budget gaps and support stronger financial sustainability, particularly amidst a changing funding environment. And again, the presenters will each get into their own rationales for braiding within their organizations. On the next slide, it gets a little bit into the how. Braiding can be described to mean different things. And in our paper that we just released, we shared this framework and thought that it can be helpful to think about braiding as taking place at two distinct levels. First is the level of the client. So is a client primarily receiving services funded by a single source or receiving services funded by multiple sources? And that's the horizontal axis here. And then on the vertical axis is the level of the staff. So are client-facing staff members funded by a single funding source or by multiple funding sources? The table here shows the primary braiding strategy that will be featuring during the webinar and that were described in the brief released earlier this week. As the table shows, organizations vary, and it's important to note that organizations can use different braiding strategies for different services within their respective organizations. And to start to really illustrate what this looks like in practice, we're excited to introduce our first presenter. So we can go to the next slide. And I will first introduce Debbie Toth, who is the president and CEO of Choice in Aging. Welcome, Debbie.
Thank you so much for having me, and hello, everybody, and thank you for being here. I think it is clear that all of our primary goal here is to make sure that we can provide the support that people need when they need it, how they need it. So next slide. Next slide, that's us. So Choice in Aging is a 76-year-old nonprofit serving folks who are in or at risk for skilled nursing placement, and we either keep them in community as long as possible or forever, or we get them out of skilled nursing and move them back to the community. We started as a polio rehab facility for children. In the 1980s, we shifted to meet the emerging need of older adults and adults with disabilities, and provide the programs that you can see listed on this slide, which include adult day healthcare, case management, intergenerational activities, caregiver support, advocacy, and more. And can I just put an exclamation point after advocacy, because without that, none of us exist. So I hope that that's in everybody's strategies. Next slide. So I want to now focus on the barriers to care that led us to braiding, because unlike what Logan made it sound like we planned it all and we have these different strategies, no, we did it organically, because very little that we do is planned. I love our nonprofit because we pivot to fill gaps And there are myriad when it comes to supporting disabled adults and elders living in community. For many, it's as simple as not knowing how to get around and where to go for what is needed, because we have what I call our institutionally biased poverty pipeline that is our de facto long-term care system. So people don't know what's available, and oftentimes they won't know what they need. So as you all likely know, your age, ability, income, primary language, and many other factors can limit your ability to receive services, and we think that's malarkey. So it's like someone thought, hey, how can we make accessing services impossible? Let's create budget deficits and artificial age barriers and require someone be at a skilled nursing level of care to receive services. And let's add a ton of paperwork to access those services. Yeah, no. So next slide. So when we saw that we had this really long wait list for folks to access our multi-purpose senior services program, that's a nurse and social worker complex case management program for people who are on Medi-Cal, when we saw that there was this really long wait list back in the day, and that our spending on their needs was very limited based on what the federal 1915C requirements were, we jumped at the opportunity when Department of Healthcare Services started talking about enhanced case management. So we got involved in stakeholder processes. How do we shape this? Sorry, that's just in California. I'm sure you have your own versions of it in your states if you're not in California. And we also applied to be a provider of what was called diversion services through the Department of Rehabilitation, because that was a much more open program that allowed a lot less restrictions and more ability to spend money where it was needed to avoid that institutional placement. We also worked locally to get a safety net sales tax passed, and we could tie that sales tax to the California Master Plan for Aging at the state level, also at the local level, so that we could identify gaps in the system and start to fill them. And I'm sure you all will be shocked to know that case management and navigating the system came up high as a gap. So some programs are richer in benefits than others, and sometimes the need is temporary, such as rental assistance 1 month because there was a huge PG&E bill, or caregiving until in-home support services kicks in. So we can navigate all of this by patching, or what our friends at CHCS call braiding, to make sure that all of these programs can work together to support this individual. We don't do it at one time. What's a distinguishing factor for Choice in Aging is they float in and out of different programs because we can't have duplication of funding on the same person at the same time. So we also use braiding when it comes to California community transitions, which you may know as Money Follows the Person, where we transition people out of skilled nursing back into community. So in this case, they have a year of case management. Oftentimes those folks need ongoing case management, so we have to have something else to plug them into. So it's seamless to the human we're serving, but it's not so seamless to us. So how do we make all this work? I would say not easily, but we do it. So first of all, your staff need to understand each program, each funding source, the regulatory body that's related to them, who they serve. Like all of our case managers and transition coordinators across the board need to know what each one of those programs are. Once the teams are all educated, we have to have a robust intake process that tells us age, geography, income, abilities, needs, etc. So all the teams work together on adapting this tool as new issues also emerge. That informs us. It's iterative. We have to change the tool. And as new programs come on board, we go back and we look at it. Does it still make sense? Are we asking all the right questions? So then we look at which program best meets the person needs. And if it's full, we can connect them to the next most appropriate program and have them on that program until a slot opens up in the one that's more robust. But if it goes beyond just how we serve somebody, it's how we document serving them, it's how we bill serving them. So we take an all hands on deck approach. Everyone from the case manager to HR to our grant writer to our finance team, they all need to be in on what database systems we're using, how we're tracking, how we're billing, how we're doing our case notes, all of those things. If everyone is not informed and trained and on board, you will not be auditable and you will risk losing the beautiful tapestry you created. So until the government gets better about barrierless access to all systems. This is our job. Next slide. And I will say this is our why, because we all want to live in a world where everyone can live with dignity, purpose, and joy. And no, that's not always Department of Healthcare Services' primary goal. I don't think I see joy in some of the regulatory language, but that's what we all want as human beings. And the end result is that we have no wait lists. People get the care they need when they need it, and it's customized to their needs. So that's all I have for Choice in Aging. Thank you so much for listening.
Thank you so much, Debbie. Next, we'll go to Katie Wilbur with RH Community Builders. Welcome, Katie.
Hi, Logan. Thanks for having me. Good afternoon, everybody. As Logan said, my name is Katie Wilbur. I'm the Executive Director at RH Community Builders, and we can go to the next slide where we are talking about braiding funds and enhancing services today. Next slide again, please. Just a little bit about RH Community Builders. We are based in the Central Valley of Fresno. We predominantly serve Fresno, Kings, Madera, and Tulare counties. We were only established about 6 years ago in 2019, so a pretty new organization. But we have maintained contracts with Fresno County DSS, DBH, the City of Fresno, Madera County, Madera BHS, as well as the managed care plans that serve our area. And this matrix of different funders has allowed us to really effectively braid services. Within the CalAIM services, we are providing community supports, the housing trio, as well as post-short-term hospitalization and recuperative care. And then we have been approved for almost all of the populations of focus, but really those that most intertwine with our mission of serving those who are experiencing homelessness. So those who are frequently the emergency rooms that have a history of SMI or SUD, as well as those who are transitioning from incarceration or those who are transitioning out of the foster juvenile justice system. Next slide, please. So why we braid, not to beat a broken drum, but we have seen it as an opportunity to increase and enhance services without increasing the use of flexible funds. We know that flexible and non-committed funds are very valuable to our funders. And so being able to bring CalAIM dollars to the table has allowed us to increase services as well as maintain services. We have a motel project with the Department of Social Services in Fresno, where the nightly rate has not increased from $85 a night since we started the contract in 2020. And so as we all know, costs of doing business have increased dramatically since then. Minimum wage in California has increased. And so being able to bring in this new funding source has allowed us to maintain staffing levels, maintain maintenance and service levels without having to go back to the county and get more money. We also think it's a path for sustainability within our organization, being able to braid funds and leverage different opportunities makes us less dependent on any one single funder, and that will make us long-term sustainable. Additionally, we do have contracts with HUD through the continuum of care, as well as other funding sources that require matches. And so CalAIM has allowed us to generate that revenue that can be our match funds for other dollars that require the match. And most importantly, what I want to talk about today is that braiding these funds has given us an opportunity to fill the gaps in our system where traditional services have left some needs. So next slide, please. In 2023, we opened 2 sites of behavioral health bridge housing in Fresno County, which combined a low barrier shelter model with really enhanced behavioral health services on site. And we saw a gap in our community that we had opened a lot of low barrier shelters, but there was a genre of clients that were falling out of shelter because their behavioral health and physical health needs were too great for sustaining themselves in shelter. And so with this behavioral health bridge housing, we were able to leverage 3 different funding sources to increase the care on site. We have a really robust care team that is serving at a ratio of 1 to 30. For every 30 clients, the care team has a lead care manager, a housing navigator, a clinician, 2 peer supports, as well as a CNA. And that's obviously much more expensive than our traditional low barrier shelter fundings would support. And so we're able to leverage the Behavioral Health Bridge Housing Operational Funds for the basic shelter operations, as well as some of our ancillary services like our maintenance and our driver, and having that nursing support while we leverage specialty mental health services to bring clinicians and certified peer support specialists onto the team. And then really finally leveraging those CalAIM services to have that case management and housing navigation that's tied into our coordinated entry system to bring the whole team together. Next slide, please. We have not been without challenges in braiding all of the services. So, contracting with managed care plans directly was a new wrinkle to historic braiding, where maybe the city or the county would braid funds behind the scenes or leverage multiple funding sources to make contracts go live. Now we as the provider was bringing one of the funding sources to the table while leveraging those other city and county funds. And it can be very challenging to balance those braided funds. We've built out our entire structure to rely on having all of the positions filled and having all of the funds coming in. But if we are underbilling or not having enough authorizations or running into other issues, that could create a gap in our funding or in our whole system. So balancing those carefully has definitely been a challenge. Locally, our managed care plans are wonderful to work with, but they do use some different payment structures, one being a fee for service, one being per member per month. And so that has created some challenges in creating usable budgets or projections because we don't know exactly who's going to have what. But we have been working closely to streamline some of those. And then, of course, every funder has different documentation, different outlines, different outcomes that we have to comply with. So being able to get all of those without creating too much duplication of service for our staff has been critical in making everything sustainable. And of course, as we know, CalAIM is a waivered service right now. We're really excited at the state's energy to make those permanent services, but there's definitely some uncertainty in the water as we approach the end of the waiver period. So next slide, please. And that will conclude my information for today, and looking forward to the Q&A later.
Thank you so much, Katie. So I'll shortly introduce our final presenter. I'll just note that if you have questions for any of our presenters or ones that you'd like to pose to all of them, we welcome you to share those in the Q&A. If it is a question for a specific person, it would be really helpful if you could just identify what speaker you'd like to answer that question. And now I will introduce Jean Straub, Executive Vice President and Chief Operating Officer of the Children's Institute. Welcome, Jean.
Thank you, Logan. Hello, everyone. Nice to be with you. Next slide, please. And next slide, please. So Children's Institute is a large multi-service agency in LA County. We support primarily low-income children and families across a variety of services. About half the organization is dedicated to specialty mental health and community health, which includes our enhanced care management and community supports. And the other half of the organization is early childhood education through Head Start and Early Head Start and home visitation programs. We serve about 30,000 youth and families through direct and ancillary services every year, and have been at the ECM work for quite a while, going back to 2018 when it was the community-based care management entity program and starting kind of the health homes pilots. We were one of the first organizations in LA County to sign on and be part of that when all of this was in Excel, and we were trading MIFs with Blue Shield and Anthem in a very antiquated way. At Children's Institute, our North Star is a belief that emotional well-being and educational success lead to economic mobility and lifelong health. And that really ties into how we see the benefits of the enhanced care management and community supports work, and really kind of building on that complex continuum of care and services. Next slide, please. So why WeBraid? It really helps us to diversify funding. It helps us to create security for staff because we are able to look at the duration of different funding and bring staff on knowing that there is continuation funding for them as we build out this business. It helps us to continue to navigate systems of care and provide the care management to clients who are coming in for other needs. We've taken the no wrong door approach and renamed it One CII at Children's Institute, which really speaks to wherever folks come from, whatever program they initially make contact with our organization through, we're offering a full array of services to them. So we are really using the care management tools through ECM and CS to make sure we are supporting them with every need, helping them get to sort of that lowest level of care that's appropriate for their needs. So if it's an emergency room user, we try and get them to primary care. If it's a primary care user, can we get them into a clinic? So we're able to sort of titrate down the level of cost and disruption for them, and really make sure they're getting the appropriate level of care when they need it and not waiting until things become chronic. Braiding has also helped us to kind of get to achievable or achieve and maintain rate across the programs, as we're able to sort of stack funding and look at how we can ensure that there's adequate funding to support the work we're doing. And lastly, through some of the California state initiatives, we have really been able to blend the care management and infrastructure funding to build out new systems. We've embraced Salesforce, and Nonprofit Cloud is kind of the engine for our ECM and CS work. And a lot of the state funding has helped us to build that out without spending the per member per month revenue coming in through the client base. Next slide. So, as I said, we are braiding lots of different types of funding. This allows us to support systems, support staff, marketing, consulting, community engagement that goes beyond the reach of the pure PM funded ability that we would have. It's also giving clarity to staff as to where their funding is coming from, what the duration of that funding is, and allows for that ability to expose our users to as many different programs and types of services as we can offer through the organization. Next slide. So, and this is going to kind of mirror a lot of what's been said previously. There are lots of challenges in the contracting and managing of these various contracts. We have 5 direct ECM and CS contracts, and we're part of an aggregator for our work with Kaiser. Everyone has different rules, different forms, different data, different timing. We're dealing with different billing rates for different services within the programs. So we have put a lot of energy into building systems, trying to manage the process for staff, trying to streamline. Originally, back in the early days, we were spending days and days and days of human effort to turn around the reports to the managed care plans. That all now gets ingested into our Salesforce platform. We have a third-party biller that takes care of all the claims management, and we spend almost no human time on those functions anymore. So we're really able to focus our efforts on being with clients, doing outreach and engagement to get as many people into the programs as possible. Next slide. So just to wrap up this part of it, and it really kind of again mirrors what's been said already. Lots of challenges. I mean, we see great benefit from the enhanced care management and community supports work, but the variety of rules, the variety of providers, the contracting, the portals, the different systems that folks are trying to bring into this to streamline things. It's getting better, but it's not great yet. So we still have to deal with multiple different portals in terms of getting data out to the managed care plans, different ways that things come back, different rules, lots of challenges. We do a lot of bottom-up referrals, which is where we're taking clients in other programs and referring them into ECM. That had a lot of challenges in the beginning, and through a lot of advocacy with the managed care plans, we were able to really simplify that process and move folks into care management much more quickly. But it has been challenging, and I think one of the biggest challenges for us is as we started this work, some of the first populations we were working with were older adults at risk of homelessness. And when you call someone like that and say you're from the Children's Institute, they really, really wonder why we're calling. So there were a lot of barriers to get over, just in terms of making contact with folks, letting them know that these benefits were something they were eligible for. There have been a lot of challenges with folks not knowing they have eligibility, not knowing that this is real, with all of the email, text, and scams that are going on. A lot of people not believing that we're legitimate providers because we're not calling from their health plan. They've never heard about any of this from their health plan. So there are a lot of barriers to get over, just to get people to embrace the services that they're eligible for, and then really get them engaged in the program. I think the last challenge, and again, this is where braiding has helped, because it has given us some additional funding to offset the caseload requirements to make the PM rates work with the type of staff and the resources that we need to have to make this effective. So we've really looked at, how can we hit the caseloads that we need for this program to be profitable. And again, being able to defray some of the technology, outreach, engagement, marketing costs with some of the blended funding has really made that possible. So we're excited to see where it goes. As we've talked about the waivers, we're really hopeful they get approved and extended, and that this work continues. But we've been at it for almost 7 years, and we'll keep doing it. And Logan, I'll turn it back over to you.
And thank you so much, Jean. We're going to actually turn it to me, if that's all right. I'm Sarah Triano, an Associate Director of Long-Term Services and Supports and Disability Policy with the Center for Healthcare Strategies. For folks who are blind or visually impaired, I'm a white woman, age 50, with like shoulder-length red, gray hair, green eyes, and I'm wearing a green jacket. And thank you to so many of you who registered and submitted questions in advance. There was one question that was asked over and over and over. So I'm going to turn it over to the panelists. I'm going to open it up to any of them to answer this question, because it was asked, and then we can go to some of the other questions that you've been submitting as well. So the question was, what would you say is the most important tool or strategy to mitigate contract-related risks with braiding? And so some of the folks had asked about, are there methods to track the funding, the document where it comes from, avoid duplicate billing, and are there best practices to ensure we're not double dipping when braiding? So again, what would you say is the most important tool or strategy to mitigate contract-related risks when braiding? Yes, Debbie.
I don't know, do you want us to raise our hands, or I don't know, but that has certainly been a step in it and learn from it situation for Choice and Aging. So that's why I talked briefly about how important it is that all hands are on deck, because we typically give the information to our case managers and hope they get it right. And we forget to tell billing, and we forget to talk to the grant writer, and we forget to talk to all the people. So it is absolutely vital that all of your program staff, from those who are delivering the care management services, to their managers, to their supervisors, to the grant writer, to the people in the finance department. So not just your finance director, but the people that are doing the billing. Everybody has to know what all of the different programs are, who they serve. So you have cheat sheets, right? So for ECM, we are getting referrals. These are Medi-Cal managed care members. They have to be in a priority population that we're serving. Like, so we do cheat sheets for each of the programs, who they serve, who pays for them, what they're covering. We have different database systems. We have different regulations for each one of those, right? So we try and do the high level, like what's in each one of these. And so as we do that one single intake form, that intake form gives us the information that tells us, oh, this person needs MSSP because they actually need a nurse, and we need to be able to purchase things through Wave Services for them. Oh, oops, there's a wait list on MSSP. What's the next program? Well, since they're applying for MSSP, we know that they're eligible for ECM because they're on Medi-Cal managed care. So then we move over to see if we can provide a referral in the Medi-Cal portal to get them enrolled in ECM. We're communicating this information to the finance team so that they're tracking where that person is in the system. When a slot opens up in MSSP, we have to disenroll them from ECM. Then we have to enroll them in MSSP. Again, we have regular meetings with staff where we're talking about what's happening. We're also documenting it in our systems so that there's not a chance for that. And our grant writer is tracking in his own system what all the different programs are, how many people we have on them, who's working in them, because some staff work on CCT and Measure X case management. Some staff work on diversions in CCT. Some staff work, so we cross-train staff. We have clear protocols for how we do those transitions. So it's just really coming up with the systems that work for you based on those funding streams. And for us, we can't have duplication of payers. So there's always a disenroll, re-enroll that happens in between programs when needs emerge and slots open. I don't know if that's clear, but
Yeah,
it's complicated. It's complicated.
thank you, Debbie. Katie and Jean, any strategies or tools to mitigate contract-related risks that you would like to share?
I think it's very similar to what Debbie was saying for us. I mean, we have a pretty advanced accounting system, so we're really kind of setting things up from that perspective. And then, really being clear with staff as to where they should be charging and where they're working. I think the biggest challenge for us in terms of all of this was with some of the infrastructure support funding that came through the state, of being really clear as to what was within the ECM scope to make sure that we were meeting the funding requirements and we weren't sort of drifting, because infrastructure is infrastructure, but we really had to keep it tight in terms of what they were willing to fund and justifying, that they weren't kind of doing broad, agency level stuff, but it really was towards the sustainability of the ECM systems.
Yeah, and I think our experience is reflective of what Jean and Debbie have shared. I think the one additional thing that I would add that also speaks to one of the Q&A questions, we haven't been super successful at getting anybody to agree to use the same billing system for different funding sources. But there are some instances where we will use one as our primary medical record for the client, and we will enter all services into there. In the instances that it's like the housing navigator that is going to be billing CalAIM, they will still enter the services into the county smart care record. They'll just enter it as a non-billable service. So we have that full client picture. But we are entering it as non-billable there to clearly iterate that we're not billing specialty mental health for it, that those funds aren't paying for it, but we are going to go bill that to CalAIM. So that's just one of the strategies that we've taken to really clearly document non-billable. We are not charging anybody else for this, and it's going to CalAIM.
Yeah, thank you, Katie.
And Sarah,
just speaking. Oh yeah, go ahead.
Oh, sorry, I was going to say, can I just quickly put a pin in what Katie just said, because I don't know who all is on this webinar, but if there are Department of Healthcare Services or other staff on here, I hope that they all heard what Katie said until they get to the point where they can do that and make it seamless for all of us. Because if it was actually generated by the state and they didn't have different database systems for every program and didn't have different regulations for every program and didn't have different reporting requirements for every program, then we wouldn't have to be doing this. So sorry.
That's okay. You're both talking about things that would make it easier for you to braid funding. Is there anything else that you'd like to add to that list? All right. Jean, we did get a question from the registration that specifically about what best practice examples can you share for braiding SMHS and ECM funding? What challenges have you come across with this?
I mean, best practice is certainly, on both sides, and it goes back to what I was saying about sort of the one CII model of, and some of what Debbie was saying too, everybody knowing everything. So making sure that, the specialty mental health folks are aware of, everything that's available through ECM. Again, it's all Medi-Cal. So, for the most part, everybody that we're serving in the mental health space is eligible for ECM services. So it really is, it's that awareness, I think, is really the best practice of people making sure they're talking to the family, because it's not just we may be working with a young child who is experiencing issues, but there may be another child in the family with asthma or some other issue that would benefit. So it's that, whole family, whole person approach of making sure they're really doing that assessment. And then it's understanding everything that ECM has to offer. And I think on the ECM side, the same thing of like, whoever they're with in that family, what are the other issues and how do we, we're very much about the multi-generational approach. So really kind of looking at everybody that's in that family unit and how can we reach them and how can we expose them again to as many services as possible that will help them and the entire family. And it's where we get back to sort of the educational success piece. If we can get those kids to school, we know that, lifelong outcomes are going to be better. Reducing absenteeism, those are the things that have that lifelong impact. And ECM is designed for that. It's that care management to take those barriers out and, allow folks to have full access to everything. So we're really trying to use that as the way to, kind of live into our North Star. Especially around sort of that educational success and for young children, making sure they're able to get to school and, we're providing those supports that sometimes aren't there to address those chronic needs.
All right. One of the other questions that came in through the registration that I'd like to just open up to any of you is, how do you get funders to work together on these complex issues? And there were two other kind of sub questions, like, what are the most important things funding organizations should know about braiding and blending by the organizations they support? And what can other funders, especially the government, do to help with braiding funding? So back to the original question, how do you get funders to work together on these complex issues?
I'll start with, I think the way that we've gotten funders to work together is to present the solution to them. And show them how we will lay out the road to do it together, and how, mutually this will be beneficial to both of them. I think the thing for funders to know or to think about is why are restrictions or why are eligibility criteria placed on specific dollars, and are there anything that we can do to remove those? Because the more funds we layer that have different restrictions, the more very narrow the population that can be served with those things becomes. And so the less restrictive, the less requirements that we can place on funds, the easier it is for us to serve a stronger team.
I would say too, the other thing that's really important is data, being able to demonstrate the benefit and the impact. So really, showing, as Katie was saying, kind of what it's going to do and really backing that up with data and supporting that. I think to the second part of the question, I think understanding from from kind of the non-government funding community, the short duration of some of these programs. There's a lot of targeted funding to try and get this off the ground. We need the long-term funding to sustain it. I mean, we really need the philanthropic community to understand the benefits. And again, it comes back to data and impact and outcomes, but understanding what this can do. And I know they did one study, and I'm not going to quote the study and I'm not going to quote the numbers because I don't have them exactly, but they were looking at the Medi-Cal savings from the initial health homes pilot. And it was profound, because when you multiply it by the number of people in Medi-Cal, it was billions of dollars. I mean, it wasn't a lot per member, but when you extrapolate that across the Medi-Cal population, it's huge. And especially with, the threats to Medi-Cal right now, with some of the cuts that are being talked about, finding ways to be more efficient with what we can do and decreasing the intensity of service. So it's not the emergency room. It's not the primary care. It's a clinic, it's an urgent care. It's that, that much lower cost model. Those are the sort of things, but it takes money to sustain this work, and it takes time to get, the client acquisition. It takes time, to convince people that these are benefits they should take advantage of, because again, they don't know they have them. And they doubt the system. So we really need a lot of hands-on engagement to get people in and working with it. And then the money runs out from the, sort of the short duration state funding, and we need to be able to sustain that.
And I would say all of that is true, Jean, and yet here we are, because we operate with our state and federal budgets as though it's a one-year finite timeline. So we don't anticipate cost shifting, cost savings. There's a brokenness in the way that we do that. So we can gather all the data in the world. And Sarah can tell you personal lived experience story about, we had this incredible program, the diversions program, through the Department of Rehab, that did what Katie said, took the handcuffs off, was like, here you go. If somebody's at risk, you can serve them. It was phenomenal. And that actually came out of feedback that was collected through stakeholders for years during the master plan for aging processes, that here's this gap. People end up in skilled nursing facilities. The SCAN Foundation, AARP, they've all studied the heck out of this. People who don't need that level of care end up becoming residents of skilled nursing facilities. And then there's no safe plan of discharge, so they live there forever, not needing that care and being at the highest cost point care and being in the last place they want to be. And so they were able to show with this diversions program that for very little money, we could keep people out of skilled nursing facilities by being able to adapt to whatever it was that they needed, whether it was an in-home care provider, whether we needed to widen the shower, whether we needed to get a wheelchair, whether we needed to connect them to accessible transportation, whatever the case was, small pennies compared to what the savings were. And yet, because those are scored savings in the future, they can't do that in the budget right now. So we can provide them all the data in the world. We are not seeing systems change. So I think we need to see systems change. We need to see that when we show the data and there is cost savings, that we need to see, where are we pulling this from the institutional bias and putting this back into the community bias? Like, those things have to shift at the federal and state level. And until they do, we are all out here doing this inefficient work of different databases, different billings, different systems, because we want to make sure that people are kept whole and in community with the wraparound support they need. So another plug for advocacy.
All right, thank you. Katie, I wanted to just come to you real quick, because in the article, we talk about something about an attachment barrier as a barrier to braiding. And I was wondering if you could share a little bit more about what that is. And
certainly. So one of the barriers that we didn't fully anticipate when we were doing our initial projections and budgeting and planning was that as CalAIM services became more popular and provided in the service, we would have clients enter our site-based programs already attached to a different provider, whether that was for ECM or for housing navigation. And that complicated our back-end funding, because I had planned for those funds to be paying the staff that are located on site full-time hours. They obviously can't go, just take more clients in because we have limited bed capacity. So we had to start accounting for that and anticipate that we would not be able to bill for all clients that are in shelter or in a site-based program for housing navigation or ECM. We try to coordinate with the teams that they are already attached to bring those extra supports in. But ultimately, I had to figure out how to still pay all of my bills in full without that full level of funding.
thank you. let's turn it to some of the questions here in the Q&A that we've got. I think there's one here. What type of metrics do you track to report impact? And that could be for anyone.
I saw Katie was still unmuted, so I thought she was gonna go. You gonna go, Katie?
No, go ahead.
Oh, so the first and ugly and honest answer is those that are required. So we're a mostly Medi-Cal funded nonprofit organization, which means we get paid less than what it costs to provide services. So we don't have a really robust data collection system in place. So whatever the regulations require that we track, we're tracking. We also recognize that the people that we're serving, we're keeping out of institutions. And so that is like a really simple thing to track. But what we have done recently is gone to folks that we know. We have a doctoral student who has her MSW and she's getting her doctorate. And we've asked her to study the outcomes of the California Community Transitions Project, which is called Money Follows the Person at the federal level, where we transition people out of institutions back into community living. So she's really looking at what the cost savings are there and what the life differences are for the folks who had those transitions. So where you can get free support to help, but she's having to dive into charts and look at all kinds of stuff because that is a project. By the way, it was started in 2008 as a federal pilot project. It is in 2025 a federal pilot project. So there is no infrastructure, there is no regulation. So we have lots of messes. And for us, it's a little more difficult tracking because it really is, we're tracking to what the regulations require. In a perfect world, we would stop and say, what is the data that we want to know that we can show? And we were able to do some of that with the TA Marketplace. When CalAIM first was launched, there was a TA Marketplace that Department of Healthcare Services allowed us to get free technical support from experts in the field. And so one of them could do some of that work and help us identify what are the things that we do want to track and do want to tell the story of, and how do we add that into the collection of data that we're already doing, and how do we plug that in? It may not be in our database system because it's not a regulation, but how do we add that to the intake form, or how do we add that to a progress note? It's messy and it's not clean. And if somebody has a much better way of doing it, I would be open to hearing it, but I'm just the reality-based programming panelist.
No, I think you're right, Debbie. I mean, I think a lot of this right now is there is so much just required data, especially with, kind of the engagement and the number of encounters and tracking all of those things just to be able to justify the billing, and, really getting to a point where, we have the right client population to really be able to look at meaningful, evaluation across, a large enough sample to, to look at where it's had benefit. I think, we're seeing a lot more anecdotal kind of evidence on the housing trio with, getting folks into housing and keeping housing and those sorts of things, because it's much more concrete of being able to really look at the impact we've had of getting a family housed and supporting them through that. We're also, as I said, we've been spending a lot on tech around this. So we're also building out our data warehouse to bring all the ECM data in so we can look at co-enrollment across programs, and is it having an impact on, the behavioral health population, that are co-enrolled, on the ECE population that's co-enrolled, and how are we able to do, sort of meaningful things across multiple programs. And also just looking at the co-enrollment of being able to get people into more than one program, and kind of keep them engaged and build relationships and do that multi-generational work and continue to work with everyone in the household.
Yeah, I think same thing. And ultimately, I think the biggest data points are going to have to come directly from the managed care plans to justify the services, and looking at cost savings on the member basis of not being hospitalized or not being in long-term care, and how these services are saving funds in that regard, and what the overall community impact is.
Yeah, because I think that's the other big thing. And I think that's a great point, Katie, because, there's lots of talk about, the HEDIS measures and, kind of meeting all of these things for the managed care plans. but it's getting this thing to a point where, you know, there's enough of a population enrolled in the programs, and we can really demonstrate that as a provider population, not just a one-off agency, but really, you know, we do depression screens for every single client. No managed care plan has 100% depression screening, but it's one of those things that we can, you know, we can provide back to the managed care plans. But we just, you know, it's about growing the, you know, the member base and really getting to those meaningful levels of population that are taking advantage of these services. And then it all starts to ripple through in terms of impact and effect and cost saving.
We've got 5 more minutes left, so I wanted to just end with one question that if each of you could answer, and we've got 5 minutes, but is there a highlight? Can you share or highlight a client success that you've achieved because of braiding?
I mean, I think for us, again, it's in that housing space of, you know, it's a small team, and there's a lot of work that goes into navigating all those systems, and, you know, having that ability to, you know, get people housed and allow them to, you know, have the dignity of housing and maintain that housing and support them, and really having a roof over their heads. I think that those are the really kind of impactful ones right now. I mean, I think those are the, you know, it's just a lot of hands-on hard work to, you know, to navigate those systems with those families. And especially, I mean, with the housing crisis in LA, to get people housed and keep them housed, and that I think those are the kind of the touching stories for us right now.
And I think along the similar line for us, one of our biggest victories with braiding and being able to bring navigation into a behavioral health field is that we have a lot of No Place Like Home housing units in the Fresno metro area that we historically had a hard time getting the right people qualified that had all of the needed criteria. And so being able to have shelter that had mental health services and clinicians who could do those assessments on site and move people directly from shelter into No Place Like Home units has really streamlined the process for our community. So I'd say that that's one of the highlights for us.
For us, I'll give a very specific example. So one of our Measure X, that's the half-cent sales tax, the safety net sales tax and Contra Costa. Most of our referrals come through APS. So somebody who has made an Adult Protective Services referral, the Adult Protective Services team has done the investigation and the intervention, but they're like, when we walk away from this person, they're going to have a myriad of other issues that need to be dealt with. And so they refer to us. So one of those referrals came into us and they needed help with home care. They weren't yet qualified for Medi-Cal, so they didn't have in-home support services. Well, they needed care right then, or they were going to be institutionalized. And so rather than have them come, so we enrolled them in Measure X because they were referred to us there. We then enrolled them in the Department of Rehab Diversions program. We paid for care to come into their home. We helped them get eligible for Medi-Cal. Then we were able to help them hire the right IHSS worker, get them trained, get them on board. Then we disenrolled them from the DOR program, and we could have them just straight on Measure X and covered in that program. But that's the beauty of braiding, is that you can put them where they need, what they need, with the most robust amount, and they don't sit on a wait list.
Thank you all. I'm going to turn it back to Logan.
That was a wonderful summation from our presenters to end. So thank you all so much for sharing your experience, sharing your strategies, and sharing your insights today. We wanted to highlight the resources that we've touched on during the webinar today, including the brief that each of our presenters, their organizations are featured in. Braiding Medi-Cal Funds to Sustain Aging, Disability, Housing, and Behavioral Health Services, as well as a prior brief published by CHCS on braiding, and with a focus on braiding Medi-Cal funds. We welcome any follow-up questions that you have. We tried to answer as many questions that came in as we could, and we really appreciate all of the great questions that you shared related to the work that you all are doing. Please feel free to be in touch if you have further questions or ideas. And I think we can go to the next slide. If you are not receiving updates from the Center for Healthcare Strategies and you'd like to hear about more events like this, please sign up or subscribe to our email updates or follow us on various social media platforms to learn about our work. And again, I would just like to thank our presenters, thank the California Healthcare Foundation, and thank you all for joining us today. Have a great day.